Welcome to the Anterior Knee Pain webinar. Hey, it's Tim from ChiroUp, and today I'm going to cover how to assess, how to treat, and what type of exercises we should give our patients with anterior knee pain. One of the things that we understand is this is a continuum. It starts with patellofemoral pain syndrome, meaning the patella is tracking laterally because it has a tendency to do that. When it tracks laterally, it irritates the cartilage, and when the cartilage becomes swollen, now we have chondromalacia. That transitions from swollen into fissuring and eventually destruction of that cartilage, which is the last stage, knee osteoarthritis. It all starts with this, patellofemoral pain syndrome. Because there's a natural tendency of the patella to track laterally, that means the patellar cartilage on the patella itself is rubbing up against the lateral femoral condyle. That causes irritation in the knee. A lot of times we call this runner's knee, but regardless of what we call it common because it affects 25% of adults and 10% of young athletes. Those symptoms are usually present when the patient is squatting and bending and lifting. Anything that they're doing that contracts the quadricep to smash that lateral patellar facet up against the lateral femoral condyle, creating more inflammation and pain. This leads to cracking of that cartilage, or what we call chondromalacia. Now, we think of this as a young person disease. Usually it's a typical young athlete, somebody who's in college or high school, but it can be any young adult or middle-aged adult. It just means that the cartilage has softened, it's now begun to fissure, and it's going to start cracking off, which is indistinguishable from osteoarthritis. Most of the time, it is in younger people, and like many of these knee issues, they do tend to affect females a little bit more frequently than males, and they certainly increase with age. That as we continue to put that stress on over time, we see more damage to the cartilage, and eventually that damage turns to thinning of that cartilage. Osteoarthritis, which affects a third of seniors, I would argue that it affects a lot more than a third of seniors. It's just symptomatic in a third of seniors. Osteoarthritis is really repetitive trauma that stresses the tissue and leads to this cycle. This is the physical cycle of swelling of that joint and softening of that joint and damage. That's what chondromalacia is. And chondromalacia is really that in-between stage between the patella not working the way that it should and the cartilage having worn away. We know that this physical cycle also has some physiologic aspects, that damage creates joint space narrowing, and that joint space narrowing, that erosion, then creates instability of the joint, which leads to some deformity of the joint. The things that we see on x-ray like spurs, that changes the mechanics, and this turns into a figure eight cycle where we just continue to have irritation to that. Now, the things that you and I see are those deformities. When we take an x-ray, we see osteophytes, sclerosis, subchondral cysts. The things that the patient present with, though, come from the swelling and the synovitis. They have pain and limited mobility. When they quit moving, they gain weight, which adds more trauma because we know that increased weight is one of the stressors or repetitive microtraumas that get this going in the first place. The things that you and I see symptomatically from an objective standpoint would be muscle guarding and joint restrictions, which are really symptoms of something else that went wrong. So what we want to do today is identify what went wrong. We know that osteoarthritis is progressive, that it often affects the medial tibiofemoral compartment, but it also certainly irritates the patellofemoral joint. That's where our focus is today, on that patellofemoral joint. This is much more common in females. They're more likely to develop degeneration of the knee, and it's also more common if you've done something to the knee, whether that be trauma or trauma that required surgery. People who have ACL repairs or meniscectomies are at a higher risk for having accelerated degeneration of their knee. We also know that if you do a lot of things that stress the patellofemoral joint, you're going to have more irritation. So people like athletes or laborers who spend a lot of time kneeling and working and squatting and getting up and down, the more times that you rub that misaligned knee, the more likely you are to develop symptoms. One thing that we know that doesn't necessarily irritate it is running. There have been a number of studies that have said that people who run do not have an increased incidence risk of osteoarthritis of the lower extremity. In fact, they have a decreased risk of osteoarthritis, even older runners. There was a study of older runners who were in their 70s and had run for at least a decade, and they had significantly less osteoarthritis than people who didn't run. Unfortunately, when you develop some osteoarthritis, there may be some discomfort with that, not necessarily from the degeneration, but from the dysfunction that created the degeneration. And that discomfort then causes people to stop moving. They have this fallacy that if it hurts, they shouldn't do it, when in fact, they need to understand, because of the way that you and I teach them, that there's a big difference between hurt and harm. And just because something's uncomfortable doesn't mean to stop moving. This person with osteoarthritis who has now stopped moving is going to have that accelerated because they're no longer stimulating that cartilage. They're no longer getting blood pumping to the area and maintaining flexibility. So things tend to deteriorate more quickly when they stop moving. Our patients who have knee problems, whether it be patellofemoral pain syndrome all the way up through osteoarthritis, typically don't like activity. It's uncomfortable. When they squat and bend and climb stairs, it's uncomfortable. They feel better when they sit down or lie down, but then it hurts again when they get back up, especially that morning stiffness. Don't forget that morning stiffness that lasts longer than 30 minutes may be something different than osteoarthritis. So you can take a look at the ChiroUp infographic on inflammatory arthropathies to help narrow that down. If somebody says their knee stiffness doesn't go away within 30 minutes, especially if it's diffuse throughout the day. One thing that we know that impacts osteoarthritis is the weather, that there have been a number of studies that says as temperature and especially barometric pressure change, so does knee discomfort and shoulder discomfort and hip discomfort. When there's relatively lower pressure outside, meaning there's probably a storm coming, there's relatively higher pressure within that joint, and the patient senses that. This is an infographic you can download from the Forms library. It's a great infographic for this time of the year to dump on social media when we do see a lot of weather changes. The reason that people get into this cycle in the first place is usually because there's some sort of imbalance in the knee, but that was a result of some sort of an imbalance in the hip or the foot. Let's keep that at the forefront of our thought process. That while the knee imbalance is where the symptom and the wearing is occurring, that is a symptom in itself. Most of the time, the knee gets pulled laterally. In fact, I don't ever remember seeing a patient where their knee was pulled too medially. The kneecap gets pulled laterally. It then causes that lateral femoral condyle to rub up against the lateral patellar facet, and the patient develops some irritation. We have tightness in the iliotibial band that does that, but more importantly, things that change the alignment of the knee globally, like a fallen arch of the foot, or weakness of the hip abductors, which help to maintain frontal plane alignment. We'll dive into those a little bit more deeply as we go today. One thing that we know is that 1/3 to 1/2 of the body weight that's the amount of compression on the knee when we walk. When we run, that goes up, and when we squat, that goes up 10 to 20 fold. So can you imagine how much pressure is on the back of her patella right now? If she's moving 135 pounds times 20, that's a lot of force. So if there's something that's not lined up properly, that force is compounded, and there's going to be some significant discomfort. The normal alignment of the knee would be that there's space in between each side, the medial and the lateral. Unfortunately, once we have patellofemoral misalignment, that lateral patellar facet is going to start to wear down, and that's where things happen. Most of the time, that happens because there's something going on at the hip or the foot. In this case, this patient has a weak hip abductor. That's allowing the knee to dive into valgosity, which puts a lot of stress on that cartilage. You can see that the natural alignment of the knee, if her leg was lined up properly, would be like the crease of her pant. It should come straight down the femur, straight through the kneecap, and straight through the tibia. Well, when her knee dives inward, because that gluteus medius up top here is not pulling that thigh outward, now the patella is going to be pulled laterally up against the femur, and that's where the wearing is taking place. Now, the muscle that's supposed to be preventing that from happening are the hip abductors. There are a number of them, but the principal hip abductor that's required for 70% of the force to maintain frontal plane alignment comes from the gluteus medius. If we look at the gluteus medius here, we can see that it comes off of the iliac crest, it's resected, and it comes down onto the greater trochanter. So when that muscle, here it is again, off the iliac crest and onto the greater trochanter, when that muscle contracts, it pulls on the greater trochanter, which pulls the femur laterally, which helps to maintain that frontal plane alignment. When somebody has weakness of the gluteus medius, in this case on the right side, this patient has a weak right gluteus medius that allows their pelvis to drop on the opposite side. It also allows the knee to dive inward into valgosity. When the knee dives inward into valgosity, what's happening is we're getting stress along the medial collateral ligament. That's getting strained. But we're also getting a pull of the patella laterally, and that's where this problem starts. So we can't think about strengthening the muscles of the knee to solve this problem later on. We need to think about strengthening the muscle of the hip. If we made the vastus medialis as strong as possible, it still couldn't overcome this biomechanical deficit. The long lever arms and the amount of force that are happening in this situation of bad mechanics can't be compensated for except by changing those bad mechanics at the hip. So one thing that we know that happens when the gluteus medius gives way, in addition to this knee buckling inward, which stresses the MCL, anytime that the thigh comes into uncontrolled adduction, there's also femoral internal rotation. And that internal rotation then torques the ACL, which puts stress on it. It helps to pull the patella laterally and also bring this femoral condyle forward to create more stress. It also torques the tibia for shin splints, and it also causes the foot to dive into hyperpronation. When the foot dives into hyperpronation, that same chain that's happening from the top down is now being compounded by going up. The hyperpronation causes internal rotation of the tibia, which causes internal rotation of the femur, further adduction, and stresses the gluteus medius. When the gluteus medius can't do its job, now it depends on the compensatory muscles, and those are the gluteus maximus and the tensor fasciae lata, both of which that attach onto the iliotibial band. So our patients who have iliotibial band syndrome or compression of the bursa or greater trochanteric pain syndrome, gluteus medius tendinopathy, all of those things, all of these diagnoses from the waist down are very related to what's happening at the hip, including a couple from the waist up. That when our hip goes into internal rotation, because it's L-shaped, it thrusts the lower portion of the pelvis forward, which then causes the thrusts the lower portion of the pelvis backward, which then thrusts the lower portion of the pelvis forward. And in order for us to stand up straight, we have to go into hyperextension. So even our patients with the most common thing that we see, lower back pain, oftentimes that's related to facets that are being overloaded. A patient who has gluteus medius weakness is going to have overloading of the facets, and it's not likely that we'll solve that through sole manipulation if we don't change that gluteus medius strength. Now, there's tons of data to say that this is not theoretical. This is something, or hypothetical. This is something that has been proven, that gluteus medius weakness leads to problems all down chain. Today, we're going to focus on what happens to the knee. But before we dive into that, let's also talk about what's happening at the foot. That hyperpronation, which means eversion of the ankle, dorsiflexion of the foot, abduction of the foot, that's going to cause internal rotation of the tibia, which is going to torque the knee. It's also going to allow the knee to dive medially. So that's going to stretch the gluteus medius, and don't forget that any muscle that's chronically stretched is probably going to become weak. So they compound each other. They're often found together. So how do we assess for somebody who has somewhere between patellofemoral pain syndrome and knee osteoarthritis? Well, all of that involves the patellofemoral joint, and patellofemoral joints don't like to squat. So if we have that patient squat, most of the time if somebody has pain coming from the patellofemoral joint, it hurts going up and down. People who have a meniscus also don't like to squat, but they don't mind so much the going up and down. They don't like bottoming out. So when they get to the bottom of the squat, meniscal pain becomes more prevalent. Another great test for the meniscus is the Thessaly test, and you can jump into the ChiroUp Clinical Skills Library to review that one. But today we'll review some of the tests associated with patellofemoral pain. Number one is the compression test. Sometimes people call this the grinding test or Clark's sign. It basically means we're going to take the patella and we're going to compress it to see if we artificially smash that cartilage together. Does the patient say, ouch? So we have the patient lying down, their quadriceps relaxed, we grasp the patella, move it back and forth, and then we apply some compression and move it back and forth. Now, realize that we really don't want to provoke a lot of discomfort. This test can actually cause problems. So we don't want to grind that until the point that they say, yes, that really hurts now. It's usually pretty obvious when it's uncomfortable. If you'd like to review any of these tests, we have a blog that came out recently. It's the knee exam. So if you go to chiroup.com, go into the resources tab and click on the blogs, just search for knee exam, or you could Google ChiroUp knee exam. And Dr. Steele and I have put together a 10-minute video of a comprehensive knee exam that goes through all of those things, like the Thessaly test and the tests we'll talk about today, but how to put that into a practical evaluation that only takes a minute or two in the clinic. Another test that we'll use for the patellofemoral pain syndrome is a patellar tilt test to say, how flexible is the knee? Remember, the knee should be centered. Since the back of that kneecap is V-shaped, it should live in the center of that groove. So we're going to say, how far can we translate that patella medially? And how far can we translate that patella laterally? And how far can we lift the patella off of the femur? that if we see that there's inflexibility on one side versus the other side, it doesn't lift as far, it doesn't translate towards medial or lateral quite as well as it should, and it's going to be limited in its medial translation, obviously, then we're going to have some issues. One thing that was more than a national board test is the Trendelenburg sign. The Trendelenburg sign means if a patient picks one leg off of the floor, they tip to the side. But if we know we're going to do that, we'll usually have this, a compensated Trendelenburg, that instead of the Trendelenburg, where that patient's hip is dropping on the non-dependent side, we'll have this compensated, where the patient's hip elevates on the non-dependent side because they know they're going to fall over if they don't compensate. Well, when that's happening, that's just putting more stress on the knee that's involved. It's also putting more stress on those lumbar facets. You can see how she's laterally flexing. She's basically doing a facet compression maneuver here to cause an increase in that discomfort. So a positive Trendelenburg means you have gluteus medius weakness. A compensated Trendelenburg means you've had gluteus medius weakness long enough to learn to compensate. One of the most essential tests for evaluating any anterior knee pain, whether it be coming from the patellofemoral joint or the tendons associated with that, which would be the quadriceps or patellar tendon, is to assess how do the hip abductors work. What we're going to have the patient do is perform a single leg squat. So let's watch this video a couple of times. First, let's watch Dr. Steele in the green. When he squats down, what we'd like to see is that his knees stay spread apart if he's squatting on two legs. When he squats on one leg, we'd like to see that the crease of his pant comes straight at us, that it's not diving medially. And we can even ramp that up another notch by having him step down off of a 6-inch step and say, does your knee still come at me directly? Now, for the next time, let's watch Christy on the left side to say, what happens in somebody with gluteus medius weakness? Well, first they have a Trendelenburg or a compensated Trendelenburg. If they're really weak, when they squat, their knees may come together. That doesn't happen often, but what does is this. When she squats down, her knee dives medially, dramatically, putting stress on that patellofemoral joint. And when she does this off of a step, it's even more dramatic. If you watch how many times her feet are compensating for this, that she's still able to squat, but there's a lot of compensations, and those compensations come with a cost, that the pelvis is dropping down, loading up the facets. Knees are diving together, causing all sorts of problems through the hips and knees. And now when she squats on one leg, we're getting all sorts of diving in of that knee, which is causing irritation of the chain. Watch her foot in this instance when she does a 6-inch step down. How many compensations occurred at the foot, and how tired are those muscles are going to become? Let's watch this in slow motion, a single leg squat. We'd like to see her leg come straight at us, but in somebody with gluteus medius weakness, that knee dives inward. And when it dives inward, the patella migrates laterally, which sets this chain of events in motion. We'll also look at the foot because that's really the foundational problem for why this started. And there's a hyperpronation cluster, and it's these four. Rather than remembering these four, let's just take a look at them. Number one is that there's excessive forefoot abduction. When there's external rotation or abduction of that foot, instead of the plane of the tibia dropping through the second digit, it drops medially. It drops through the first digit. In a lot of patients, it'll be dropping even more medial than that. It'll drop off the edge of the foot. So just looking at that patient. We can also look at them from behind and say, what's happening to their Achilles tendon? Is it nice and straight, or is there a bowing of that Achilles tendon? You can see on his left foot, there's dramatic hyperpronation. And it has a test name associated with it. This is a fancy test that you'll want to write down. It's called the too many toes sign, meaning that if we look at the patient from behind, either standing or walking, we see more toes than we should. We should only see the lateral 1 or 2 toes if their tibia is lined up properly. If not, if there's hyperpronation, we'll sometimes see the whole foot. Now, the American College of Rheumatology gave us some criteria for the diagnosis of knee osteoarthritis. Number 1, you're really old, like me. Number 2, you have morning stiffness, but it doesn't last more than 30 minutes. Number 3, you have bony tenderness or bony enlargement if it really gets dramatic, and a lot of times that crusty joint starts to make noise. But usually there's not warmth associated with knee osteoarthritis. Warmth or morning stiffness that lasts more than 30 minutes would indicate some inflammation that may be an inflammatory arthropathy. One thing that we'll often see in our patients who have advanced from simple patellofemoral pain syndrome into chondromalacia later stages, and especially osteoarthritis, is that there's swelling in those joints, including the joint capsule itself. And remember, a lot of the bursa around the knee and the joint capsule will communicate. And there's no set pattern saying this bursa and this bursa. It's different in all individuals, but most of the time, their joint capsule communicates with the popliteal bursa right in the very back of the knee. When that popliteal bursa blows up, it fills up with fluid, it becomes a Baker's cyst. That's not an unusual cyst that grew there. It's simply a cyst that is filled. The popliteal bursa is filled. Think of it as a series of rivers and lakes. When the lakes overflow because there's too much rain, it's going to run downstream to one that has the least pressure. And in that case, the one with the least pressure that's not being compressed by a bunch of tendons and bones is the popliteal bursa, so it blows up. One of the quick screens that we can do for somebody is just feel the back of their knee. If you feel a water balloon back there, it tells us there's some sort of swelling in the knee. If they had acute trauma, that could be blood that's filling up from a ruptured ligament or a fracture. And if they're older, it's probably synovial fluid from osteoarthritis. If there's redness and warmth in the knee, we could be concerned about an infection, but that'd be less common in the popliteal bursa. So what do we do for our patients who have some degree of patellofemoral pain syndrome through osteoarthritis? Well, number one, we can mobilize the tissues that are holding that patella laterally. So we'll use our factor tool or a Graston instrument to scrape through the adhesions on the knee to help loosen that up. I like to go around the patella when we're done with this. Their patella should be outlined with a little red line where you've stimulated some blood flow through that area while we're mobilizing. Something else that we can do is to mobilize the patella to lift it. We don't want to do the grinding sign, but we can lift it and pull it medially or laterally, especially medially because we're trying to stretch those lateral retinacular tissues. We can also work out the quadriceps. A lot of patients who have this problem have tight quadriceps and hamstrings. The quadriceps trigger points typically develop in the upper part of the muscle or in the mid portion of the muscle. And to work those out, we're going to work them out the same way we'd work out any other muscle. We take that muscle from a shortened state, trap the trigger point, and then strip over the top of it. So Dr. Steele's going to take Christy's leg. He's going to shorten that muscle a little bit. And then he is going to stretch that muscle to lengthen it as he strips over the top of the trigger point. We'll do the same thing with the TFL because remember 70% of the force required to maintain frontal plane alignment when we squat comes from the gluteus medius. The other 30% comes from the gluteus maximus and the TFL, both of which attach to the iliotibial band. So trapping that muscle and stripping one leg down behind the other as we're going through the muscle can help to loosen up that TFL. Rather than the TFL, as opposed to the ITB, which really isn't going to stretch much. Remember, the ITB is firmly attached to the femur its whole length. It's like an I-beam. So it's not a strip of bacon that's lying on the outside of the thigh. It is a very stiff piece of fascia that then has a membrane that attaches to the femur to make an H, or an I-beam basically. And its job is to prevent the femur from fracturing when you jump off of a truck bed or a ladder. That if there weren't the iliotibial band present to tighten up, if I jumped and I had a little bit of medial adduction stress, my femur would want to migrate laterally and it would snap. Well, if the iliotibial band is very taut, it will push up against and hold the soft tissues against the femur to prevent that from happening. The same thing going medially. Rather than letting the femur dive medially and snap that way, it hangs on to the femur. So the iliotibial band can't be very flexible. In fact, it has the flexibility of something close to steel. A lot of people will roll this out or work out the iliotibial band. There's a lot of data to say that's probably futile. Now you can work out the springs that attach to the iliotibial band, which would be the tensor fascia lata and the gluteus maximus, but working the band may not be the best investment for you or the patient. Sometimes it feels good, but it's probably not changing the length of the iliotibial band. We'll also want to work out the gluteal muscles, especially the gluteus medius. Here it is again, coming off the iliac crest, attaching onto the greater trochanter. Its job is to abduct the hip, and it develops trigger points because it's usually chronically stretched, because it becomes weak and then gets more and more stretched. So we can use some soft tissue work to work through that gluteus medius, especially as we get up toward the iliac crest, or we can do a pin and stretch where we trap a trigger point, have the patient bring their knee up and into adduction as we strip across that trigger point. We'll also want to work the hip adductors. Remember when Christy was squatting and her thigh was buckling in and outward as she was trying to compensate? Of course, that's going to turn on and off the adductors, so stripping out those trigger points is essential, as is the hip flexor, because most of the time when somebody has hip abductor weakness, they also have a bigger problem, which is called lower cross syndrome, meaning they have weakness of the gluteus medius and they have weakness of the transverse abdominis, but they have hypertonicity of the iliopsoas and the lumbar rectors, something that you and I see on a regular basis. So stretching and stripping those muscles. Now, all of these videos you can review in ChiroUp. If you go into the clinical skills library, you'll be able to play the video to see if there's any one of them that you'd like to review in greater detail. One thing that we definitely want to do is to make the patient an active participant in their recovery. So we're going to have them stretch out a few muscles. Number one, their calf muscles. Remember, the gastroc gets stretched with the knee straight. The soleus would be stretched with the knee bent. We really can't get to the soleus if we don't take the gastroc out of the way. So we'll first stretch out the gastroc with the knee straight, and then we'll stretch out the soleus with the knee bent. We'll also want to loosen up the hamstring. That a lot of times people who have imbalanced strength in their quadriceps and hamstrings have more issues. Having too tight of a hamstring and too weak of a quadricep is really one of the risk factors that dramatically increases your likelihood of developing anterior knee pain. I like to do the hamstring stretch lying down on the floor. That yes, it can be done more potently standing, but most of our patients will mess that up. They will bend forward at the waist regardless of how many times you tell them just to move your ribs towards your hips. So one way to prevent that is by getting them to lie on the floor, push up against a door frame, and then scoot closer to that door frame. Yes, they can only get to 90 degrees here, but how much beyond 90 degrees do we need to get to have a healthy hamstring? We'll also stretch out the psoas. Remember, it's going to tighten up. We can either do that kneeling or standing. And the key to a psoas stretch is to lead with the ASIS, to have that patient stand up straight, lunge forward, now push their leg forward against the resistance of the floor, relax and lunge forward a little bit further. And as she lunges forward in that process, she's getting a good stretch of the psoas and a little bit of the TFL. Mainly for the TFL and the ITB, which again, we're only stretching the TFL here, we're going to have that patient stand against a wall, pivot their hip forward and drop their hip into the wall. If a patient does this exercise at home, you know there's an instant feedback mechanism. And it's called, they come in on the next visit and say, how do I do that stretch? Because if they don't ask you how to do that stretch after you've told them, they didn't try that stretch. The thing that a patient will mess up universally is that they'll let their hips drop backward. Well, as soon as their hips drop backward, they put a ton of slack in the TFL. It's not going to stretch. The only way we stretch it is to make sure the hip comes forward. So one thing that I'll do for the patient in office as a cue is to stand in front of them and grasp their front pocket and pull their front pocket forward while I put my other hand on the front of their shoulder and push their shoulder backward. Once that patient has that scissoring action down and realizing they're trying to drop this hip into the corner in front of them, not behind them, they'll tend to do better with that exercise. And then probably most importantly, we want to build strength in the gluteus medius. And the clam series is a proven way to do that. Clam 1 is really simple, having the patient lie down and spread their knees apart and then back down again. Anyone can do this. That grandma who was on the couch earlier can absolutely do a clam with the band, even on the couch. When that gets easier, we're going to put a band around her knees and have her do a clam with the band, which provides some additional resistance. So again, almost anyone can do this exercise to begin strengthening the gluteus medius and rehabbing. Now, once they get to the point that those are easy, we're going to step it up a notch. We're going to start them with something easy, but then we're going to move them into an advanced clam. And for this, we're solely rotating the femur. That her ankles are going to come together, but only because she rotated her femur. So one thing that I'll do is I'll just put my hands around their distal knee and make a circle that their leg can pivot in and have them pivot their leg back and forth in that circle. Once the patient is able to do that, they can run this exercise at home. If you've not done this at home and want to know where your gluteus medius is, then try about 20 of these. You'll know where your gluteus medius is the next day. This is a potent exercise that, again, almost anybody can do. Even grandma on the couch could probably do this after doing a couple of the other clams to warm up. One thing that we'll want to not forget about is if there are fallen arches of the foot, a couple of things can happen. That there's a handful of proven treatments. In fact, there was a systematic review last year of 65 different trials that said there are a couple of things that work from a conservative perspective for knee osteoarthritis all the way down. And it's number one, hip strengthening exercises. Number two, manual therapy of the lower extremity, and number 3, orthotics. So orthotics are something that are going to be beneficial for our patient if they have hyperpronation or fallen arches. But if we can teach that patient how to potentially improve that arch and prevent hyperpronation when they're walking, that'd be even better. It's the difference between giving your patient a long-term lumbar support belt or giving them core strengthening exercises. Let's give them foot strengthening exercises if we can first. And the posterior tibialis strengthening is one of those great exercises. Have a patient wrap a band between both feet and then try to look at the bottom of the top foot is what I tell the patient. Drop the band back down, look at the bottom of your top foot as you roll that back up again. That's engaging the posterior tibialis, which comes down behind the medial malleolus here and then attaches onto the undersurface of the foot. It's a natural arch supporter, so we can give that patient their own intrinsic arch support as opposed to just an orthotic. I hope that you've been able to get something from this webinar. If you want to review any of the skills, go to chiroup.com, click on your clinical skills tab, and under condition reference, you can type in patellofemoral pain or hip abductor weakness, whatever condition you'd like to review. There's 150 of them now. You can look at any of the tests associated with that. You can open up the test, and there you'll get the narrated version along with all of the verbiage. Same thing for the exercises. If you have an exercise that you'd like to review, it's in there, and the data that supports these best practices, which are mined on a weekly basis by our team of 4 doctors. Great news is to prescribe this to a patient, hit the Quick RX button, choose your patient's name or add them with just their name and email, and at that point in time, you're going to be given a menu that you can choose the diagnosis. In this case, we'll make a condition report for patellofemoral pain syndrome. We are done at this point. We click Save. And now the patient is going to have a report with a picture that details in 6th grade language, here's what's wrong with you, here are the things that I can do to help you, here are the things that you can do to help yourself, which are specific to that diagnosis, and most essentially, here are your exercises at home. So within 4 clicks, you can send this information off to a patient. I hope this information has been useful for you. I hope that it ups your management of knee pain, anterior knee pain. If you have any questions, I'd love to hear them. If you have any suggestions about how you treat things differently, I'd love to hear that too. I'm Tim at chiroup.com. Thanks for watching, and I look forward to connecting next time.